okay?
Yes, we can. Thank you.
Good. Okay. Well, I want to acknowledge the land in all of Alaska of the Alaska Native people, and I also want to say that I found out 2 weeks ago from one of my cousins that I know that my mother's family is Ibert, comes from Quebec. And I found out when she went back to the 14th century that there is Quebec First Nations relatives that we have in our family. So that was pretty exciting for me to learn that. So I came to Alaska in the early 1970s. I spent 2 years in the Yukon-Kuskokwim Delta and worked as a physician in the hospital there, just in general physician. Did my specialty training and ended up as a hepatologist. And now I work in Anchorage. And if we could have the next slide, please. So as everyone has said who's talked already, that there's very high rates of hepatitis B in Alaska Native and American Indian and Canadians, First Nations people. We've tested about 30,000 people. The population is about 170,000 Alaska Natives. And we've treated 1,000 people with DAA, and we have a high SVR rate, but that is reflecting the fact that we've picked people who are not necessarily continuing to use injecting drugs. We offer it to everybody who uses injecting drugs, but it's really hard to get those people in. And I've learned so much from the presenters before me about the need for community health workers to go out and work with these people and help to bring them into the clinic who are still injecting drugs. So that's a real big challenge that we have. We just started a program with one of the other tribal organizations, South Central Foundation, in the homeless shelter to try to screen and treat there. Now, of those 1,000 people that we've treated and with DAAs, 600 are in Anchorage. And the local primary care tribal organization, South Central Foundation, has transitioned that from physicians to pharmacists. So that really creates a lot more efficient system. 400 are in rural clinics, and these rural clinics are located, these are rural hospitals and large clinics located in the big cities of Alaska, which are big cities meaning about 10,000, 15,000, such as Nome and Ketchikan and Bethel and Utqiagvik, which used to be used to be Barrow, the new indigenous name. Fairbanks, and those places where we have good primary care providers and some internal medicines and pediatric specialists. However, we know of 180 people that are living in rural isolated villages. There are over 200 in Alaska off the road system. And these people have tremendous barriers to not only accessing treatment, but even to get screening. They have to fly 2 to 4 times to the nearest facility, sometimes more than 150 kilometers away by plane, to get treated by a licensed provider. So that's a huge challenge for us. Next slide, please. Now, one thing in Alaska that we've seen is that we could eliminate, if we had enough resources, we could eliminate hepatitis C in the Alaska Native population, but that wouldn't really eliminate in the population because there's so much interaction between Alaska Native people and people of other racial and ethnic groups. So we have developed a program with the state of Alaska, the Alaska prison system, the needle exchange program, the homeless shelter, the federally funded community clinic, and the private sector. It's called the HOG. It's not the animal hog, but the Hepatitis Alaska Working Group. And we meet on a regular basis. We've been sort of not being able to meet as much with COVID, and we work together to try to eliminate hepatitis C. In the prison system in Alaska, there's a disproportionate number of Alaska Native people in prison. 20% of people in prisons are infected with Hep C. They are now screening everybody, and they are offering treatment to anybody who is going to be there for at least 6 to 9 months. Next slide, please. Now, one of the things that we've done is because we had a lot of providers after interferon that were afraid of hepatitis C, afraid to start treating patients. So we developed a one-day program with the state and with the prison systems and others to educate nurses, pharmacists, and providers about hepatitis C, and give continuing education credit for free. There was no tuition. And they learned about the epidemiology, what are the screening strategies, how to use the direct-acting antiviral medications, how to fill out the various insurance forms and free drug forms to get everybody treated. And then this has expanded the number of providers in Alaska from a dozen in 2015 to well over 100 statewide that are comfortable treating hepatitis C. Next slide. So how do we reach those people that are living, the almost 50% of the population that are living in the isolated communities that aren't getting these services now? So we've we've got a grant from CDC to start, and we are putting in a PCOR grant today. Actually, it's going in today. And we are going to develop a program based on the program we use for the primary care providers to train the indigenous community health aid providers. So each one of these 200 communities has a little clinic, and they have a person from the community that receives 16 weeks of training, is certified by the state of Alaska. They run the clinic. They can't prescribe medications, but they're on the phone with the doctors all the time. They do have a pharmacy there. They learn how to suture, draw bloods, take care of urgent emergencies. So these people, these community health workers, are the perfect people to treat hepatitis C. And so this grant is to start out in 5 villages to screen all the residents using a rapid fingerstick HCV test from 18 to 80. If they're positive, they'll draw blood, spin it down, send it into our laboratory. We'll do the PCR test. And then what we'll do is using telemedicine. This is different from ECHO because we'll have the patient present and we'll have the health aide present. We will treat that patient by several visits so that it's one-stop shopping. Get screened in your own community, get treated in your community, and you don't have to get on an airplane 3 or 4 times to fly to the nearest facility. And then as part of the PCORI and the CDC grant, we're going to compare the rates of SVR that we obtain in these villages, in these communities, to the rate that we get in the specialty clinic, our specialty clinic in Anchorage. So hopefully if we get the PCORI, we're going to expand to 25 communities, and then we'll gradually get the tribal organizations to implement this in all communities. Next slide. I think that's the last slide. So anyway, I am really happy to hear about what the other speakers have said, and I realize now that we really need to figure out a way to get community health, to get advocates to help us to get patients that are difficult to treat, such as those who are continuing to use injecting drugs. And so that, in addition to treating people that live in rural communities, is our big challenge for the next year or two. Thank you very much.
Thank you very much, Brian. And Brian, Jessica, I didn't know if you had any questions